Good morning, everyone. I'm Jennifer Martin. I'm here this morning to talk to you about the use of wrist actigraphy in the diagnosis and management of patients with sleep disorders. I'm a professor of medicine at the David Geffen School of Medicine at UCLA. I'm the Associate Director for Clinical and Health Services Research in the Geriatric Research Education and Clinical Center at the VA Greater Los Angeles. The only disclosures that I have are research support from the NIA and the Veterans Affairs, and I'm also a member of the AASM Board of Directors. Those are not directly related to what I will be talking about today, but I wanted to make sure that you're aware of those issues. So first, some housekeeping. Throughout the presentation, if you have questions, there's a Q&A panel either at the top or the bottom of your screen, and you can see what it looks like here. See if I can grab a pointer right here. So you can use the Q&A panel to post questions, and then at the end of our time this morning, I'll handle all of the questions at once. The webinar is being recorded, and within a couple of weeks, it will be posted on the AASM website, and the link for that is shown here. So here's what we'll go over during our hour. I'll talk a little bit about the basics of wrist actigraphy. I'll talk about the role of actigraphy in the diagnosis of sleep disorders according to the International Classification of Sleep Disorders, 3rd edition. I'll spend most of my time reviewing the updated clinical practice guidelines for the use of actigraphy in sleep medicine, which were published fairly recently. And then I'll wrap up by talking about some of the real nuts and bolts and kind of technical issues of using actigraphy in clinical practice. So the basic premise of using actigraphy to estimate sleep parameters is that movements are frequent and large when people are awake, but once they fall asleep, movements are smaller or absent. The devices are worn on the wrist for multiple 24-hour periods. And the key advantages and the reason why wrist actigraphy can be a useful tool is that the person can wear it in the natural sleep environment. So if they sleep at home, you can capture what their sleep actually looks like. And so this overcomes some of the issues that we see in laboratory testing where we may not be capturing the person's real life experience. The duration of the recording has to be between 3 and 14 days. I'll talk a little later about how we might decide how many nights of information we need. That's really influenced by what we are trying to evaluate in a given patient. So what the device does is it samples movement every few seconds, and then those data are stored on the device itself. And then we use a reader or an interface to upload the data from a device to a computer. And device-specific software is then used with built-in algorithms to score the data for sleep and wake and to generate summary information. Now notice that this is different from what we see with consumer wearables now. Consumer wearables are usually connected via some kind of wireless method, and the data are uploaded instantly. The challenge for clinicians is that consumer wearables, you can't look at the data epoch by epoch, and the algorithms are proprietary and not necessarily validated for patients. So I'll comment periodically as we go through this about consumer wearables and the role that they might play in the future. But for now, our confidence is lower for consumer wearables because we don't have the same level of validation of the algorithms used. And in fact, some of the devices, we don't even know much about the accelerometer itself and whether it's similar to the ones that we see in the devices that are approved for use in clinical practice. So I wanted to give you a little bit of history about where actigraphy kind of came from in terms of its use in clinical practice. In 1995, the first practice parameters for the use of actigraphy were published, and the consensus at the time was that actigraphy was useful as a research tool, but there wasn't sufficient information on its use in patient populations to indicate that it was a diagnostic tool that could be used in clinical practice. For some of you, this might seem like a long time ago, but I actually remember when this was published. It was around the time that I started my graduate degree. And so I think it was great because we felt confident in using it in our research, but at the same time, I think a lot of us also felt like it had some potential for use in clinical practice that was limited because the available evidence at the time didn't include research with patient populations. So in 2002, about 7 years later, the practice parameters were updated. And again, the available data suggested that actigraphy was actually very reliable for measuring normal sleep in people who were healthy without sleep disorders. But again, there was no evidence for the use of actigraphy in clinical applications, so in patients with sleep disorders. After these practice parameters were published, things started to change. And one of the reasons was in the ICSD-2, I think there were some challenges in how we quantify sleep time when we're diagnosing sleep disorders. So that was published in 2005. And then the practice parameters were again updated in 2007. And by this time, by 2007, there actually were a number of studies looking at actigraphy in patients who were part of clinical populations. So in this case, the evidence base had grown substantially over that 5-year period. And this practice parameter update includes some specific statements about special populations where actigraphy can be useful. For example, in patients who have cognitive impairment, who are not able to reliably report their sleep, or in whom polysomnography is not likely to capture the daily variation in sleep-wake behaviors. So this was a shift in thinking based on emerging evidence. And when I think about this, I think about from 1995 to around 2005, over that 10-year period, there actually was tremendous growth in research on use of actigraphy in clinical patient populations. So in 2013, the ICSD-3 was published, and actigraphy is specifically talked about in the context of a number of sleep disorders, which I'll talk about later. And in 2018, updated clinical practice parameters, which we now call clinical practice guidelines, were published. And based on the evidence now, actigraphy is indicated to assist clinicians in a variety of sleep disorders. So one of the things to point out again is that over 20 years or so, the evidence base changed pretty dramatically. If any of you are ever in Los Angeles, you can come by my office and see what those first-generation actigraphs looked like back in 1995. It almost looked like wearing a deck of playing cards on your arm. So we've definitely come a long way in device design as well. I do want to also mention that I was part of the task force that updated the clinical practice guidelines in 2018. So if there are any questions about those guidelines, I'd be more than happy to answer them. So let's go back and talk briefly about the use of actigraphy in the diagnosis of sleep disorders. So in the ICSD-3, there are indications for the use of the multiple sleep latency test. And one of the key aspects of conducting a multiple sleep latency test is that you document adequate sleep before the diagnostic test. There have been a few studies in this regard. My group actually finished up a study regarding the use of actigraphy prior to the MSLT not too long ago. And the key advantage of actigraphy over sleep logs in advance of the MSLT is that you have a better ability to quantify sleep at night, accounting for sleep disturbance. So what we see is that when we ask patients to keep a sleep log, that sometimes they're not as aware of their nighttime awakenings. And remember, this is not the case that we might see for insomnia, for example, where people overestimate how much they're awake. In patients with hypersomnia, they may actually underestimate the degree of sleep disruption, and so actigraphy can help us capture that. The recommendation here is that actigraphy is used when possible for 1 to 2 weeks prior to the MSLT. Again, the idea being that we can get a more precise estimate of total sleep time. There's another advantage that we don't quite think about as much, and that is that patients can wear the Actigraph for 24 hours a day. So another useful aspect of actigraphy when we're evaluating hypersomnia is that we actually can see sleep during the day. Now, the algorithms that are used are typically validated for measuring sleep at night when the person is in bed and intending to sleep. But as a clinician, when you look at the tracings that you can get from actigraphy, and I'll show an example later, you can start to see patterns of daytime napping that can also be very informative in terms of diagnosing hypersomnia. Actigraphy can also be used in the assessment of idiopathic hypersomnia. So again, it's preferred over sleep logs. So the total 24-hour sleep time of greater than 660 minutes on 24-hour PSG or by wrist actigraphy in association with sleep logs averaged over 7 days of unrestricted sleep. So the reason that I actually like actigraphy when we look at long sleep time is that when we have only one 24-hour period of PSG, which is very hard to do anyway, either to have someone in the lab for 24 hours or to get 24 hours of home PSG with valid information, is that we can see what things look like on average across multiple days. So actigraphy, in my opinion, is actually a better way to quantify hypersomnia with long sleep time. Another potentially important use for wrist actigraphy is in quantifying insufficient sleep. So the patient's sleep time established by personal or collateral history sleep logs or actigraphy is shorter than expected for age. So again, a sleep log can be very useful, but sometimes doesn't tell the whole story. And I can think of an example from my own practice where I had someone who said that they went to bed at 10 o'clock and got up at 6, but what they neglected to put on the sleep diary is that from 10 until 2, they were actually in bed with an iPad, watching television and not really sleeping. So I think especially in populations like adolescents or groups of patients where the sleep log is difficult to maintain, or you suspect that that there is some reason why they might want to over or underestimate sleep relative to what's actually happening, this can be a really useful tool. Another thing I'll mention is that in research studies where we're looking at experimental manipulations based on a history of getting adequate sleep, actigraphy is strongly preferred over sleep logs in those situations. So when, for example, a research participant is incentivized to be fully rested when they come into the lab for an experimental study, it can be really problematic if they're sleep deprived because, as you know, it changes sleep architecture in a number of different ways, and it affects performance and learning and things like that. So in those instances, the standard in research is to use actigraphy rather than patient self-report. So here's an example. A 19-year-old college student presents with extreme difficulty falling asleep 4 to 5 nights a week and resulting sleepiness in his morning classes. He's concerned he might fail calculus. He describes a similar problem in high school, stating that he would catch up on sleep every weekend. You suspect delayed sleep phase syndrome. How long should you record actigraphy in this patient? So one of the things to keep in mind is that if we want to get, for example, a quick snapshot of someone's total sleep time or a quick snapshot of their normal sleep routines, we might use a short duration of recording. But here's an example of a patient who tells you that his sleep schedule is different on different days of the week. So in this case, we would want a longer duration of recording. So 24 hours wouldn't be enough. We might catch him on a night where he's sleep deprived and making up for sleep, or we might catch him on a night when he has to get up early for class. 2 or 3 days probably isn't enough, again, because he told us that it's a little different on the weekends. So the correct answer here would be 1 to 2 weeks. Some people have suggested that an even longer duration of recording could be useful. My take on this is that if we actually tried to record for a very long period of time, one of the downsides of that would be that we would delay initiating treatment. So a week or 2 is usually enough. when I'm evaluating someone like a college student, I do want to think about whether they're in class or on vacation from school. For people that have variable work schedules, things like that. I had a patient a few years ago who was a high school teacher who came to see me in the summer, and she was very delayed, but got sufficient sleep. The problem was when she went back to school in the fall, when she was going to have to get up early, that's when it became an issue. So we do want a couple weeks of recording, and we want to think about the context of the time that we're doing that. So doing the 2 weeks of recording over winter break for a college student might not be the best idea. You actually might want the recording conducted while they're taking classes. So actigraphy with a sleep diary for at least 7 days is also mentioned in the diagnosis of a number of other circadian rhythm sleep-wake disorders. So what you can see oftentimes in delayed sleep-wake phase disorder is that the sleep onset and offset are shifted later. And because of the way the data are displayed, this becomes very obvious. And I know that, sometimes people think a sleep diary is the way to go. And obviously a sleep diary can be very useful. But I also find that sometimes it's helpful to show the patient what their sleep habits look like over the course of a week or so. In the case of advanced sleep-wake phase disorder, you would see the opposite, where sleep onset is early and sleep offset is early. Irregular sleep-wake rhythm disorder, where there's no major sleep period with multiple irregular sleep bouts, specifically more than 3 per 24 hours. In my early work, we used actigraphy in patients who had dementia, Alzheimer's disease, or other forms of dementia, where irregular sleep-wake rhythm disorder is a big problem. And you can really see on the tracing that for some individuals, day and night are indistinguishable. And for others, they have a more consolidated pattern where most of the sleep is happening at night. And again, by recording multiple days and looking at the pattern across days, you can really capture some of these issues. Actigraphy can also be useful in the evaluation of non-24-hour sleep-wake phase disorder. And I would say that one of the most useful things about actigraphy here is that the patients that I've seen with this problem tend to present with intermittent insomnia with daytime sleepiness. So their presenting symptoms sometimes is that they have a period of insomnia with sleepiness during the day, which then gets better and then comes back again. And if you can record, in this case, it may take much longer than 2 weeks. You may actually need a month or more of recording. But if you can actually see on the actigraphy graphs the shift in timing for the major sleep period across days. So I actually think actigraphy can be very helpful here. In terms of shift work disorder, actigraphy can also be used. And one of the things that I find useful about actigraphy and shift work disorder is it ends up being a way to talk to the patient about insufficient sleep in the context of shift work disorder. So as a clinical psychologist who does behavioral interventions, sometimes having objective information about sleep helps shift workers understand why they're so tired and sleepy, and we can work on a plan to try to get them sufficient sleep while they're doing shift work. So from the diagnostic rubric, the ICSD-3, I'm going to shift focus now and talk about the AASM clinical practice guidelines for the use of wrist actigraphy. But before I do that, I want to touch briefly on clinical practice guidelines in general. So clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. I think it's really important when we read guidelines that we keep this in mind, that the whole goal of a clinical practice guideline is to use the evidence plus benefits and harms of alternative care options and the care option that's being reviewed to make a determination about how a given diagnostic tool or intervention should be used. So clinical practice guidelines are also not intended to tell you what you have to do, and I'll get to this in a moment, but I think it's really important to be focused on the notion that these guidelines are designed to optimize patient care. So there are some considerations in clinical practice, like whether an insurance company will pay for something or not, that inform guidelines less. One might, for example, think that a harm is that out-of-pocket costs for patients are high. But if the tool itself is so useful or the intervention is so effective, then a guideline might still say it should be first-line treatment. The other thing is that as technologies come and go, there are some times where a technology may be more harmful or less beneficial than a new technology or a new treatment. And in that case, the guidelines are updated and some treatments that we used to use in the past may no longer be recommended. So it's not just the intervention or the diagnostic tool alone, it's in the context of other available treatments or diagnostic tools. The recommendations in the guidelines define principles of practice that should meet the needs of most patients in most situations. So notice that it doesn't say all. We all in clinical practice come across certain patients where we know what the guidelines say and we know that it's not the right course of action for a given patient. So that's very important to keep in mind as well. So the recommendation should not be considered inclusive of all proper methods of care or exclusive of other methods of care reasonably used to obtain the same result. This caveat is also important because technologies change, new treatments emerge, and as you saw from what I showed earlier, clinical practice guidelines tend to be updated every 5 to 10 years. So in that intervening window, new studies are published, new technologies are developed, so things change. And the most important one is the last one, which is that the ultimate judgment regarding propriety of any care must be made by the clinician. And I would add by the clinician by working together with the patient. So even if a guideline says that this is a strong recommendation, there are instances where the clinician may choose to do something else. And there may be interventions that are not discussed in clinical practice guidelines that a clinician might choose to use. Sorry about the formatting here. So the way that recommendations are worded is either strong or conditional, or in some cases you'll see strong or weak. And the direction can either be for or against. So a strong recommendation in a clinical practice guideline is one that clinicians should, under most circumstances, always follow. So again, there will be exceptions, but in general, in practice, this is something you should always follow. I didn't say something you should always do because sometimes the recommendations are to not do something. And I can give you a recent example from my own experience. I had a son with a sports injury, and when we looked at the guidelines, it said that doing x-rays was not recommended unless symptoms did not improve over a specified time period. So one temptation would just be to start x-raying immediately, but the guidelines actually said that the x-ray is unlikely to be informative unless symptoms persist for a long period of time. So this is important to keep in mind. We sometimes have a recommendation that's a strong for, but sometimes we have a recommendation that's a strong against. Now, a lot of the recommendations that you see, and this is true in the Actigraphy guidelines for certain, are conditional or weak recommendations. And what this reflects is a lower degree of certainty in the appropriateness of a given patient care strategy. So it doesn't mean that you shouldn't use the treatment. What it means is that there may be more alternative options, that there isn't a sufficient number of studies to say we should do it most of the time, or that there are a number of downsides to the approach that might limit its overall utility in practice. So a conditional recommendation reflects a lower degree of certainty and requires the clinician to use clinical knowledge and experience and refer to the patient's values and preferences to determine the best course of action. So it may be, again, that in the case of Actigraphy, there are multiple ways to use to establish total sleep time prior to an MSLT, and a clinician may choose to use Actigraphy. It's one option. It has some significant benefits, but it's not something that one has to do before an MSLT. We don't have sufficient confidence to say patient self-report isn't good enough for most patients. So the clinician should use their own experience and knowledge to make that determination. The other thing about a conditional recommendation is that one has to look more closely at the individual circumstances of the patient and the clinician, and I would add here the clinical setting. So, for example, if you are treating patients in a rural area where getting an actigraphy device back at the end of 2 weeks is going to be very difficult, you may choose to try a sleep diary first, because that could easily be dropped in the mail or faxed or scanned and emailed, and an actigraph would require, it would be a little more difficult for the patient to return. So again, a conditional recommendations means it's something that is going to be useful in some cases, but not necessarily a strategy that you'll rely on most of the time. So here's the citation for the clinical practice guideline document. It is published in JCSM in 2018. I'm going to go through each of the recommendations and talk a little bit about the literature that supported them and some of the considerations that led to the strength and direction of the recommendation. So the way that we structured the literature review is again, thinking about clinical practice, we actually looked at categories of sleep disorders as our starting point. So we reviewed the literature on use of actigraphy in patients with insomnia disorder. And the two recommendations that we had is that we suggest that clinicians use actigraphy to estimate sleep parameters in adult patients with insomnia disorder. And this was a conditional 4. Part of the rationale for that is that objective monitoring is not required for the diagnosis of insomnia. So insomnia is sleep disturbance with daytime consequences at least 3 times a week for at least 3 months. So it's the patient's experience of poor sleep that leads to a diagnosis of insomnia. However, sometimes objective estimates can be very useful. So one of the areas where it might be particularly useful is in patients who are non-responders to cognitive behavioral therapy for insomnia, which is first-line treatment. Again, in my own practice experience, when there are patients who report very short sleep time, but have very few daytime symptoms other than concern and worry about insufficient sleep, actigraphy can be very helpful. We used to call this condition sleep state misperception. That's not a separate category anymore, but I find that actigraphy can be very useful in terms of actually reassuring the patient that they're getting more sleep than it feels like they're getting. Sometimes that in and of itself can be very useful for patients. The second recommendation is that we suggest clinicians use actigraphy in the assessment of pediatric patients with insomnia disorder. One of the challenges in pediatric sleep medicine is that we're often reliant on the parents to help us track progress and sleep itself, which inherently has some problems. And we actually found reasonably convincing literature that actigraphy can be helpful in evaluating pediatric patients with insomnia. And one other interesting thing about the literature is it includes pediatric populations with developmental disorders. So this is a subgroup of pediatric patients who might have a hard time with the sleep log, and actigraphy was useful, not just in terms of diagnosis, but also in terms of measuring the impact of treatment approaches that are taken. Next, we looked at the literature on circadian rhythm sleep-wake disorders, and the two recommendations here are that we suggest clinicians use actigraphy in the assessment of adult patients with circadian rhythm sleep-wake disorders, and that again was a conditional 4. And the second recommendation is around pediatric, and again, this literature included pediatric patients with developmental delays. So the thinking here is that actigraphy provided information that was different from what was reflected on sleep logs or patient questionnaires, suggesting that it gives us slightly different information. I find this a very helpful tool when I'm trying to distinguish between insomnia disorder and a circadian rhythm sleep-wake phase disorder. patients who have an extreme extremely irregular schedule, which might be either part of insomnia or part of a circadian rhythm disorder, this can be really informative and I think help with the differential diagnosis. And again, I think when we're doing intervention, so if we're using light therapy or melatonin, that we can use actigraphy to help us monitor a shift in the sleep period as well. So in the guidelines prior to the recent ones, there was information that using actigraphy as in combination with a home sleep apnea test can increase the precision of the AHI. And since that previous guideline, there were actually a couple of additional studies comparing home sleep apnea testing devices with and without actigraphy. And so this continues to be a useful tool. There is at least 2 home sleep apnea test systems that have actigraphy integrated now. And, you know, we sort of hope that this might move the needle in that direction for more devices. Because as you know, one of the limitations of home sleep apnea testing is that we don't know when the person is actually asleep. And so in some instances, the apnea-hypopnea index is underestimated. So it's the number of events per hour of recording as opposed to per hour of sleep. If we have actigraphy to give us a good estimate of sleep time in these patients, we can get a more precise AHI. Now, one of the important considerations here is that this is not, the suggestion is not that a home sleep apnea test with actigraphy replaces polysomnography. We're talking specifically about patients who would be appropriate for a home sleep apnea test in the first place. So if one is thinking of a home sleep apnea test, one with integrated actigraphy can provide a more precise estimate of AHI than one that does not include a method for quantifying total sleep time. I mentioned this earlier when I talked about diagnosis of hypersomnia disorders, but actigraphy can be used to demonstrate sufficient sleep prior to the MSLT. And our recommendation here is that we suggest clinicians use actigraphy to monitor total sleep time prior to testing with the MSLT, and this would be true for both adult and pediatric patients with suspected central disorders of hypersomnolence. This is again a conditional 4, suggesting that it is a viable option, but not something that clinicians will always do. Now, in this instance, actigraphy should be used for at least a week, so 7 to 14 days. And there's something else to note. It also can be helpful, not just in documenting total sleep time, but in looking at the person's typical sleep patterns. So for example, if you have a patient who doesn't wake up until 10 o'clock in the morning, but then the night that they're in the lab before the MSLT, they wake up at 6, 7, or 8, that may influence your interpretation of the first nap opportunity on the MSLT, because the week prior, that was actually part of their normal nighttime sleep period. Another thing to note is that actigraphy was not viewed as a replacement for PSG the night prior to the MSLT. And so I think that's important to consider. I think we had questions about whether PSG was a good way to capture adequate sleep time the night before the MSLT, but there wasn't really literature to inform whether that actigraphy could be used instead. And given that we oftentimes use that PSG the night before to capture other abnormalities, it seemed best to continue to have the PSG the night immediately prior to the MSLT. One of the other caveats is that you can't bill insurers simultaneously for actigraphy and PSG. So what one would do is end the actigraphy recording when the person comes into the sleep lab the night before the MSLT. So this was a new area of literature that we looked at for the updated guidelines. It was not actually covered in previous guidelines, and that is evaluation of insufficient sleep. The literature in this area came primarily from people who were at occupational risk for insufficient sleep. So shift workers, people who work extended periods of time, like first responders, physicians who with complicated call schedules, people who work in industries where they're one of the examples I remember is people who work on oil rigs where they do 12-hour shifts that rotate periodically. And in this instance, the duration of recording probably should be a little longer. Again, the CPT code only allows for actigraphy to be billed up to 2 weeks. So that's something to keep in mind. But in the literature that we reviewed, the recording duration was typically longer in the range of 2 to 3 weeks as opposed to 3 to 14 days. And again, this is a conditional for, meaning it's an option to consider. In my own practice, I found this very useful for patients who present with hypersomnia. And if you ask them how much they sleep, they give you a socially desirable answer, like 7 hours a night. When you actually put an actigraph on them and have them go home, you find, again, that either, true, they're in bed for 7 hours a night, but they're not sleeping that time because they're in bed but doing something else. Or you find that they do sleep 7 hours a night sometimes, but on other nights they're up very late. In the Los Angeles area, long commute times are a big challenge. So a lot of people have to get up very early in the morning to get to their jobs. And they end up very sleep deprived by the end of the work week. So I think it can be really helpful in these patients to use actigraphy to help quantify their sleep time. And then it can be helpful in terms of informing strategies to increase sleep time and then reevaluate with those strategies in place. There were some studies on use of actigraphy in place of EMG for the diagnosis of periodic limb movement disorder. And when we reviewed these, our initial thought is that actigraphy might potentially be useful. One of the challenges in diagnosing and treating periodic limb movement disorder is that we make a diagnosis and then we treat someone, and it's unlikely that we will actually reevaluate them. So we thought actigraphy might actually be useful for looking at treatment response. But what we found was actually the opposite. So there was a very low correspondence between the periodic limb movement index as estimated with EMG compared to an actigraph, in this case placed on the foot or ankle. Most of the research in this area is also with one specific device. So it's hard to generalize from that one device to any of the other commercially available devices that we might use. So in this instance, we actually landed on a strong against. And the main reason is that there wasn't evidence that that using actigraphy was sufficiently precise to inform treatment. It would potentially delay treatment if you had to then do a polysomnogram. And that the other concern is that because PLMD is often treated with medications, that you could misdiagnose someone as having PLMD when they don't really have it, and treat them with a medication that could potentially have harms or side effects. So this is the only instance where we landed on a strong recommendation, and in this case, it's a strong against. So we felt pretty strongly that EMG should continue to be the standard for diagnosing periodic limb movement disorder in both adult and pediatric patients. So I'm going to shift gears again and talk about the usefulness of actigraphy in patient care. So here's an example. This is a patient that came in, and we were wondering whether this person had insomnia or a circadian rhythm sleep-wake-based disorder. 58-year-old man who came in with a complaint of insomnia for years. He said his schedule is difficult to describe. Each night is different depending on how he slept the night before, which is something we hear a lot from patients with insomnia. Sometimes he just gives up trying to sleep and gets out of bed early to start work. He works from home as an IT security consultant and has a flexible schedule, so he can work whenever he wants. He had an in-laboratory PSG about a year before he came in to see us, and it showed normal sleep architecture and efficiency, and his AHI was 2.7. He's generally healthy and active, but he's concerned that his sleep problem, he's concerned about his sleep problems, especially by waking up when the whole world is sleeping and being unable to fall back asleep. So we weren't exactly sure what was going on with him, and the exceedingly normal PSG kind of gave us some questions, and he did tell us he slept pretty well the night he was in the lab. So we asked him to wear an Actigraph for a week to characterize his sleep. And so this is what we got. So let me point out here, this is 8 p.m., midnight, 6 a.m. Each day is plotted in a row. This is the rest interval that's automatically detected by the software. So when we use this in practice, we go back and use the patient's log, which I'll talk about a little later, to establish the bedtime and get-up time. The black lines indicate the level of activity. The yellow is light detected by the device. And on the bottom here, you see red. And if it's red, that means that the algorithm scored him as awake. So one of the things that we noticed right away is that on at least 2 evenings, that he actually fell asleep quite early, despite the fact that he told us he didn't go to bed until much later. And it looks like here that even though he's still awake, the light is very dim, and here as well. We see a lot of awakenings during the night, so his sleep quality is poor. And the other thing that we see is we see these early morning awakenings. So 4 a.m. Is right here, and he is waking up quite early, oftentimes not going back to sleep again. So his sleep quality is poor, but we did start to question whether he might have advanced sleep phase syndrome. In this particular patient, what we did is we worked on trying to keep him awake a little more in the evening. We implemented light therapy, and we borrowed a few strategies from CBTI, set a regular wake time, and talked about what he was doing when he was awake in the middle of the night. And part of the rationale there, as you can see in some of these, that he's up in the middle of the night and he's turning on the lights. So we worked on his sleep habits and kind of what he did in the middle of the night, but ultimately we used a circadian intervention. So in this last section, I'm going to shift and talk about the kind of the nuts and bolts and the technical issues of using actigraphy in clinical practice. So the first is, and I don't take anything from device companies or manufacturers, so I'm going to be very objective about this. One has to consider the cost and the services included when you purchase a device for clinical use, just like any other device you would purchase for your practice. There's a huge range in prices, from a few $100s to over $1,000 per device. The software, the interface, warranty, maintenance, tech support. Some companies have these included as a package. Some companies offer an option to lease the devices. Some don't. So do a little homework. If you go to the sleep conference, I actually think a great thing to do is to go down to the exhibit hall and wander around and talk to the manufacturers and look at their devices. It does matter to patients what they look like. We actually, patients kind of, a lot of our older patients who still wear a watch, or I guess now people wear Apple Watches, so I don't know how this would work. They actually like a device that has a watch face on it, so they can just take off their own watch and wear it instead the week of recording. Think about your typical patient. So if you see a lot of pediatric patients, you need a device that is small and light. This is also something that I find really a problem with a lot of the devices that are on the market, and that is that the wristbands aren't sufficiently adjustable for patients who are very thin or very heavy. So if I have a patient who is obese and large and has very large wrists, sometimes I have a hard time getting a strap that is big enough. And in some of the work that we did in nursing homes, where we have a lot of frail older women with very tiny wrists, sometimes it's hard to secure the device so that it's snug enough that it captures movement. So think about the patients that you see in your practice when you're looking at devices and make sure that it will actually fit them correctly. You want something that's relatively durable and water resistant. The example that I showed you is a device with a light sensor on it. I find this very useful in terms of scoring, and as I mentioned in that particular patient, we used it to make some recommendations about what he would do when he wakes up at night to minimize nighttime light exposure. I mentioned this, but what are the actual features that are included? It's nice to have a device with a button on it where you can mark events. There are some devices that include an option for patients to rate things, which can be very nice when you're evaluating hypersomnia disorders. You can have the patient actually rate their own level of sleepiness throughout the day. And I think this is particularly relevant for pediatrics, but you'd want to know that the device actually has been validated in the patient population that you see. So the devices made by large manufacturers typically have been, but some of the devices, which I think are enticing because they are less expensive, made by smaller companies, may not have been validated in the kinds of patients that you see. And one of my concerns is that many of the consumer wearables, I think I can still say this as a blanket statement, have not been validated in any patient group. Some of them have been validated in healthy, normal sleepers, but not in clinical patient populations. And as we know, patients with sleep disorders have different patterns of sleep, and they may have different patterns of movement when they're awake in bed at night. So that's something to be careful of. So another thing is, I think we're all tempted to just slap an Actigraph on someone and walk away. But you really need some collateral information so that you can capture what's happening during the patient's major sleep period. The best tool to use is daily sleep diaries. I have a citation down here at the bottom, which was a handbook, basically, that a group of us wrote in collaboration with the Society for Behavioral Sleep Medicine that talks about some of the technical issues of using actigraphy. So if you're thinking about implementing actigraphy in your practice, I would actually suggest that you get your hands on that. Or if you can't, you can just contact me and I can share it. Because I think that when you start looking at the step-by-step scoring of an Actigraph recording and what we should look for in terms of, clean data and artifacts, that we really do need at least a basic sleep diary, and I'll show you an example in a minute. In research, sometimes we actually use telephone diaries, so instead of having the person call in, we have them write it down. You definitely could use a sleep diary app. Light exposure is a great way to try to figure out whether someone is in or out of bed. Sometimes we can use questionnaires about usual sleep habits, but this is only useful if the person has regular sleep schedules. And in some of our inpatient studies, we actually use nursing staff observations to help inform our interpretation of actigraphy information. So this is really all you need in terms of a daily log for actigraphy. I think sometimes people feel a little overwhelmed by a comprehensive sleep diary. But really what we need to know is when the person got into bed, meaning they turned off the lights planning to sleep, and what time they got up in the morning to start their day. That will become the major sleep period that we look at when we calculate things like total sleep time at night or sleep efficiency. Then we also want to know if they took the device off. So a lot of devices now include either a temperature sensor on the back or some way of figuring out whether the device is actually on a person or not. And those features seem to work pretty well. But the thing is that if the person took it off, for example, to go swimming, we certainly could assume that they were awake during that time. If they took it off because they went to the movies, then we wouldn't really be sure if they were awake. So I find it helpful to have them tell me if they took it off, why. This is another alternative for a very simple sleep diary. It's available on the AASM website. There's also the AASM Consensus Sleep Diary, which includes the questions I mentioned before and a number of other questions if you want more detailed patient reports. So one of the critical things about actigraphy is that once you get the device back from the patient, that you review it very quickly. And one of the reasons is that if something doesn't line up, sometimes you can ask the patient what happened, and they may have, they may be able to still tell you. So you might identify inconsistencies because the diary information doesn't match the activity or light data. The most common reason is that the documentation is inaccurate. We spend a lot of time in our research studies trying to figure out how to make sleep diaries easy for people to use. And every once in a while, we'll still get a person who mixes up the dates or puts the time in the wrong place or something like that. The other thing is that the devices do periodically malfunction, so very low or very high activity levels for a chunk of the recording can be a concern. Sometimes if you don't have an off-risk detection feature in the device, the person might take it off for an extended period. And every once in a while, there may be a problem with how the device was set up to record data or how it was downloaded. The algorithms used to score sleep and wake are device specific. Some manufacturers allow you to change the algorithm. For example, they have a pediatric algorithm and adult algorithm. But basically, get the manual from the manufacturer and then talk to people you know who use the device. The first step is to identify the major sleep period, which is what you use the daily log for. The automatically scored rest intervals are not sufficiently reliable in patients with sleep disorders. It's appealing to use that, and they're relatively accurate in people who are healthy, normal sleepers, but in sleep disorders patients, they're not. Then you use the automatic scoring algorithm for sleep and wake. The AASM task force that did the guidelines before the most recent one made some recommendations about which algorithms to use. And as I mentioned before, consider the validation of the algorithm specifically in the patient population that you're using. And if it's a pediatric population and there's a pediatric algorithm, it's best to use that. Then you generate a summary report that will give you information about sleep and wake during each major sleep period and during each, most devices, which I find very useful, also give you information about the periods of time outside of the major sleep period, which is one way to capture if someone is sleeping a lot during the day. And then that's what you use for interpretation. So the common variables reported for the major sleep period include total sleep time and percent time asleep. These two variables are highly reliable, and in fact, the correlation between total sleep time from Actigraphy and PSG is about the same as interscore reliability. So I think that's really useful to keep in mind that we actually get a very good estimate of these two things. The number and length of nighttime awakenings is less reliable, but again, in the example that I showed, you can see that this person has multiple awakenings during the night. The exact number may be less important than what you see on the plot. And sleep onset latency is a little trickier because if Actigraphy is not as good at detecting N1, so it may, again, in some populations, healthy, normal sleepers, it might be okay, but it's not indicated as a way to objectively quantify sleep onset latency, for example, in insomnia. I alluded to this before, but one of the other advantages is that we can measure daytime sleep, and that can be very useful, although we do need validation of the current algorithms and the assessment of daytime sleep in patients who are actually sleepy. So I think we have some information that it overestimates sleep in healthy people, but that's not surprising because healthy people tend not to fall asleep at all during the day, and Actigraphy tends to detect a few minutes of sleep here and there. So here's the procedure code for Actigraphy, and one of the things about the clinical practice guidelines is that the AASM actually shares them with payers and encourages them to provide guideline-based care. So we've actually been able to move the needle in this particular instance in the case of sleep apnea diagnosis and treatment, and we plan to use the guidelines and have been using the guidelines in the same way for advocating for compensation for risk actigraphy. So make sure you understand the definition of the code and that it can't be billed in conjunction with PSG. Local coverage is really variable. This is all informal polling data that I've done with my friends, but coverage ranges anywhere from $0 to $250 for the code. In some clinics, patients pay a set out-of-pocket fee. It's not commonly established what that should be. When I, again, talk to my friends and colleagues, it's somewhere between $50 and $250 for the procedure. In our clinic, we actually just do it as part of our diagnostic workup. But hopefully the payers will start considering this more seriously with the new guidelines available. So in summary, actigraphy is suggested as an option in the assessment of sleep parameters in patients with insomnia and circadian rhythm sleep-wake disorders. It can also be useful to inform assessment of sleep-disordered breathing with home sleep apnea testing. It should not be used as a replacement for PSG with EMG in the evaluation of periodic limb movement disorder. Another important point is that scoring should not fully rely on automatic detection of the rest period, but should involve hand scoring of the major sleep period. And I want to end with one comment, which is consumer products are not going anywhere. And how that will impact clinical use of actigraphy remains uncertain. So it may be that we get to a point where the algorithms in those devices are sufficiently reliable that we can use them to inform our clinical decision making, but we're not there yet. So I will end with that. Here are a couple of key citations that I mentioned: the clinical practice guidelines and the technical guide for the use of actigraphy. And now I will shift over to questions. I see one question up now, and I will start going through them. So the first is a comment about a recently published paper that compared actigraphy in consumer wearables and PSG in 57 adolescents, and with the conclusion that both Actigraph devices underestimated total sleep time and overestimated WASO compared to PSG. So one of the interesting things is that I imagine that these were not clinically referred patients. And I also would be curious, there are differences between boys and girls in terms of movements during sleep. So I would be curious about that. I remember just seeing this paper briefly. And again, the other caveat is that I don't know how the Fitbit scores sleep and wake. And this is far from the first paper to show that the sleep staging is not accurate. And I do get patients who contact me and say they want to actually come and see me for insomnia treatment because their Fitbit says they don't get any REM. So I find that to be kind of problematic. Again, I think that the device companies are trying to do better, but they still have a long way to go. So thanks for that question. The question, how much does PLMD affect the results of actigraphy, if at all? I actually am not aware of any studies that looked at the impact of PLMD on actigraphy estimated sleep quality. But I think that's actually a great question, whether one could use sleep quality in a patient with PLMD before and after treatment, for example, as a measure of the benefits of treating PLMD. I'm not sure I know the answer, but I think that's actually a great question. So the next question, can I describe how actigraphy estimates sleep? So, actigraphy, the way that the algorithms work is that they take a given epoch. So usually set the epoch duration to either 30 seconds or 1 minute. And then it includes that and several adjacent minutes to come up with an activity count. And the minutes adjacent to the one that you're scoring are weighted. So the ones obviously closest in time are more heavily weighted. So it's sort of like a moving average. And then different algorithms use different methods for making a determination about whether to consider a given epoch sleep or wake. So for example, you could use the detection of any movement at all, which would be very sensitive. So in populations where patients don't move a whole lot, that could be useful. You could have a threshold. So some of the software includes a high, medium, or low threshold that you can use. And then for some of the devices, there are multiple methods, like a kind of an area under the curve method of determining whether a given epoch is scored as sleep or wake. So again, one of the challenges is that most companies don't tell us their algorithms. Some do, and they'll give you a citation to a paper with a mathematical formula in it, but some of them don't. Am I familiar with that? Let's see, let me resolve that. And the next question is, am I familiar with the ActiveWatch device to assess leg movements during sleep? I believe those were some of the studies that were included in our systematic review. And again, the challenge is that if we use the diagnostic criteria for periodic limb movement disorder, the sensitivity and specificity for a PLM index greater than 5 is not very good. I don't remember specifically, this might have been the device where if you use a different cutoff, if you use a very high cutoff, then the sensitivity and specificity is better, but clinically that's not what we use to inform treatment. So as I mentioned, I do believe there was one study in our review with the ActiveWatch device. Well, we are pretty much at the top of the hour. One more question. For use with MSLT, do you keep the watch on during PSG? This is a great question, and because you can't bill for actigraphy and PSG at the same time, it's probably best not to do that. I actually don't know if you would need to remove it or if you would just consider the end of the actigraph the day before the PSG. It might be interesting as a scientific exercise to look at the correspondence between total sleep time on the actigraph and the PSG the night before the MSLT. But again, in clinical practice, I'm not sure that you would be able to bill for the actigraphy and the PSG at the same time. Well, thanks again, everyone, for your attendance and for the great questions there at the end. Have a great day.